Between financial and physical well-being is well documented. The cost of health care can deplete a family's savings, and many patients simply don't or can't access the care they need. In low-income areas, the vicious cycle of suffering has profound long-term consequences for both individuals and communities. In the town of Clarksdale, Mississippi, home of Muddy Waters and Sam Cooke, many low-income families rely on payday lenders to meet emergency medical and financial needs. In turn, a family's financial instability can contribute to anxiety, stress, and negative health outcomes. Today, I'm proud to announce a commitment by Southern Bancorp, working with the Aaron E. Henry Community Health Services Center in Clarksdale and the Community Development Bankers Association, to improve both health outcomes and financial inclusion. Together, this unique partnership between a community financial institution and a community health provider will reach people where they are, integrating financial development and social services on site to test and demonstrate the social determinants of health. Through this commitment, patients will be screened and referred to credit counselors as needed. The clinic staff will also be offered financial interventions, promoting economic stability, economic mobility, health, and wellness. These commitment makers will not only address social determinants of health in a primary care setting, they'll also create a framework for community development financial institutions and federally qualified health centers to work hand in hand. I know firsthand how powerful community development financial institutions can be as pillars of community transformation. The model of cooperation is replicable and scalable, and one that should be supported in communities everywhere. I want to congratulate the commitment makers on this exciting new project.
Hi, good afternoon. Thank you so much for joining us. I'm Francisca Lucian, Director of Health Equity with the Clinton Global Initiative. We're excited for today's conversation on how we support, partner with, and invest in local communities. Very briefly, just to highlight some of the need, only 1% of vaccines administered across countries in Africa are locally produced. The other 99% are imported. This is just one example of the gaps and challenges that have been brought into sharp focus during the current pandemic and have enormous impacts on health and equity more broadly. But there are strategies and solutions that can close the gap and foster long-term access, equity, and health of communities, which is what we will explore today. We are excited for this morning's session and discussion on equity-centered strategies to localize systems in ways that strengthen access, delivery of services, and build long-term resilience. It is my honor and pleasure to introduce a public health advocate and champion for equity to lead today's conversation, Chelsea Clinton. Please join me in welcoming her.
Oh, well, thank you for that warm introduction. Thank you, Francisca, for all of the work that you've done over the last many months to embed health equity throughout the CGI meeting and to convene conversations like this one. It is so good to see so many familiar faces in the audience, and it's also quite good to see some unfamiliar faces in the audience. And the way that you all responded to what I just said hopefully validates that you feel the same way. As is expected, hopefully by now, before we begin our panel conversation, we are so thrilled to start with a couple of commitment announcements. And first, I'd like to invite to the stage Her Excellency Ambassador Minata Samutseumu. Did I say that right? I did not say that right at all, and you're going to tell me how I should say it more correctly. And Nikolai Gilbert from PATH. Her Excellency is from the African Union. As you heard in the statistic that Francisca shared, many countries, not only across Africa, but really around the world, have underdeveloped health product manufacturing capabilities and capacity. That then leads to not only relying on imported vaccines and therapeutics, but also other medical commodities and supplies. Increasingly, natural disasters caused and exacerbated by the climate crisis are destabilizing and disrupting vital supply flows and threatening the well-being of vast numbers of people. The COVID-19 pandemic exposed and exacerbated these supply chain fragilities, leading to enormous disruptions and bottlenecks. This further led to elongated timelines for the access to desperately needed vaccines and therapeutics, including, of course, the COVID-19 vaccines. Overall, 68%, and hopefully all of you, of the world's population has received at least one dose of a COVID-19 vaccine. But that figure drops to 21% when we look at under-resourced countries. In-country manufacturing of health products is essential for improving global pandemic preparedness and response, to ensure that vaccines can be produced in the places where they need to be administered, and ultimately building the resilience that at least wealthy countries give rhetorical support to. Oh, thank you for laughing, although hopefully you will, those of you with platforms, continue to push those with resources to do more and to follow the example of our commitment makers today. So the African Union and PATH are partnering for a commitment to develop a set of principles for investing in African manufacturing of devices, diagnostic tools, drugs, and yes, vaccines, and a plan to align manufacturing initiatives with funding sources urgently. As part of this commitment, leaders from the public and the private sectors will combine their technical expertise, political influence, policymaking power, and agency and funding to strengthen local economies and expand access to urgently needed medical supplies. This is clearly critically important and will only succeed at the scale that it is required if everyone who is in this room and not in this room is engaged and supportive with whatever championship or resources you may be able to give it. So while I'm going to ask you to, of course, applaud, I'm going to more ask you to think about what you can do to help. You all got very quiet. Hopefully that's because you're thinking about what you can do to support the African Union and PATH's commitment. And now I'm very pleased to ask to come to stage my friend, Peter Sands, the Executive Director of the Global Fund. Peter, you come to stage. Yes, okay. And with music. I mean, I don't think I got music, so. But as some of you know, Peter is working very hard right now in advance of the replenishment meeting tomorrow. And so Peter probably needs all of the musical support and caffeine, and dollars, euros, yen, pounds, and other currencies that you can provide to him and to the Global Fund in advance of tomorrow and certainly subsequently. As you've heard throughout this meeting, and as I know many of you are acutely aware, we do not have a sufficient supply of professional health workers anywhere in the world, certainly not here in the United States, not across the global north, and acutely not across the global south. This shortage has a number of ricocheted effects in patients' lives and in public health, including the improper or lack of diagnosis of diseases. This in turn contributes to unnecessarily high and preventable rates of illness and mortality from otherwise treatable diseases. As I know many of you know, and if you don't, you will hear more about this, the Global Fund raises effectively billions of dollars a year and then invests those dollars in programs to help tackle this and many other challenges. Health equity has been a center of the Global Fund's work for many years now across the more than 100 countries in which it has helped finance programs to prevent and to treat not only HIV/AIDS, tuberculosis, and malaria, but to really build effective and efficient health infrastructure. Something that I do think is important for this conversation we're having today is that increasingly over the fund's lifetime, country ownership has gone from a goal to reality, with a focus on localization and local empowerment. And yet that can only be a reality when those with resources invest in it. And so by raising funds from wealthy governments, from the private sector, and from NGOs, the Global Fund certainly has had and continues to have a transformative impact on people's lives and on populations around the world. It is pretty extraordinary that the Global Fund can not only claim but prove that it has helped cut the combined death rate from HIV, tuberculosis, and malaria by more than half over the last couple of decades. And so I really do think that all of us need to do all that we can to support the Global Fund, partly because of the two things that I want to mention briefly now that Peter will further elaborate on. Because one of the things that I most admire about the fund is its relentless focus on what more it can be doing and how better can it do it. That it is truly an innovation incubator and engine. And so two new commitments anchored in and engaging the Global Fund. First, the Africa Frontline First Catalytic Fund, a mouthful, but an important commitment, hosted by the Global Fund, will provide financing to pay, sustain, empower, and grow the frontline community health workforce in up to 10 countries across Africa. It will also importantly ensure that women who make up a substantial portion of the community health workforce are properly paid for their work. Additionally, the Catalytic Fund will offer funding and technical assistance to implement and use the supplies, digital tools, and life-saving equipment needed to build solid healthcare infrastructures and to protect healthcare workers. Johnson & Johnson Foundation and the Skoll Foundation, along with the Global Fund, are the anchor partners, and they have committed to mobilize at least $100 million from across the private sector. And all of you here can help with that. The second new initiative that I want to mention is the Outcome Fund for Fevers, or OFF for short, also a global fund, catalytic fund, that will target fevers, including malarial fevers in sub-Saharan Africa, where the failure to diagnose dangerous fevers often results in delayed treatment, especially for children, leads to heightened risk of antimicrobial resistance that no one in the world should have to confront, and the potential to miss the threat of an impending pandemic, something you would think by now we would have understood as an urgent priority and yet seem to not have. The OFF Fund will provide financing to scale the diagnoses, the treatments, and the data reporting for malarial and other fevers, accelerating community response to disease threats through rapid diagnostic tests, combination therapies, digital equipment, and data reporting. And while one of the first areas of focus will be on malarial fevers, the hope is that soon there will be a truly comprehensive effort to help diagnose and treat fevers and to save lives, particularly those of children. The partnerships, again, of the public and the private sectors are critical here. And I want to acknowledge how proud we are at the Clinton Health Access Initiative, where our CEO, Dr. Buddy Shaw, is standing off to the side to be part of this work. And certainly, if I haven't said enough, we need all of you, and whatever you're doing, it's not enough, because we all need to be doing more. And the Global Fund proves that it is always possible to imagine more and to do more, and to give us all more detail on the more and how we can help. I now want to hand the lectern and the microphone over to Peter.
Even as the executive director of the Global Fund, I'm always a bit nervous talking about the Global Fund in front of Chelsea, because Chelsea wrote her doctorate thesis on the Global Fund. And so she actually knows rather more about it than I do. But Chelsea, huge thanks to you for your championship and partnership, and to the Clinton Global Initiative and to Chai. We have an incredibly deep relationship with all aspects of the Clinton family and foundation. As you mentioned, tomorrow is quite a big day. We have this replenishment conference hosted by President Biden with the ambition of raising $18 billion US dollars. That's not really what counts. What counts is that with $18 billion, we can save 20 million lives over the next 3 years, and that by 2026, having cut, as Chelsea said, the death toll across the 3 diseases by half, we can cut it by a further 2/3 by 2026. That is an enormous prize if we can make it happen, when we make it happen. Now, it's not just about big money. It's about partnerships, it's about communities, it's about the private. That's the magic of the Global Fund. And we use these catalytic funds that Chelsea mentioned to stimulate, to generate. So we're talking about, for example, with the Africa Frontline First Catalytic Fund, $100 million. But actually our ambition is to use that to catalyze spending of over $1 billion over the next phase on community health workers, because we see that as one of the most powerful levers in improving health and well-being. And likewise, with the outline, I always forget, the outcome fund for fevers. This is part of a shift from being very disease-focused, asking the binary question, does this child have malaria or not, to asking the broader question of why does this child have a fever, and therefore what we can we do about it? And it's about catalyzing the change towards that. So I would like to welcome on stage some of the wonderful people and institutions who have really stepped forward to help make these catalytic initiatives possible. And as I call your names, I'd love you to join me up here on stage. First, for the Africa Frontline First Catalytic Fund, thank you, Lauren Moore from Johnson & Johnson Foundation, who are committing $15 million. I'd also like to welcome Don Gibbs from the Skoll Foundation, who are committing $10 million, the anchor investors. I'd like to also thank the partners from the Africa Frontline First Initiative supporting the design and advocacy. Thank you, Dr. Angela, I knew I'd make a mess of it, Gichahaga, and Dr. Madeline Ballard. And please extend our thanks to all the other AFF member organizations, and we must acknowledge the fantastic role that Her Excellency President Sirleaf has played. She's not here today, but she's been a fantastic champion for all of this. Second, for the Outcome Fund for Fevers, Buddy Shah, get up here on Clinton Health Access Initiative, Martin Edlund from Malaria No More, and Krista Weisman from Global Citizen, and also representing MPX, who are helping us raise funds to scale this further. I also want to thank a good friend, Alison Moore from Comic Relief USA, a long-standing partner, and they're announcing $10 million pledge, unlocking. She's managed to do a great deal here. She's unlocked a 2-to-1 match from the Bill and Melinda Gates Foundation, which means she gets $30 million. And then the way the US government pledge to the Global Fund works is it's a 1-for-2, so the other way around, up to $6 billion. So for every $2 you put in, you get 1 from USG, which means actually, Alison miraculously has managed to turn her $10 million into $45 million, which is quite an achievement. Now, individual philanthropists, people who put their own personal money, are making a massive and really important contribution. And I really want to acknowledge one particular philanthropist who has made a contribution here, Ms. Thuy Yong from Vietnam, who is committing $3 million, and which the Gates Foundation have matched to provide a total of $9 million. So, fantastic people stepping up. Thank you very much. So, Chelsea, what do we do now? Have a photograph.
Yes, let's take a photograph. Yes. Well, Peter, here, I'm going to give you this.
Oh, I
gosh.
forgot about that.
Yes, you take that.
I take that.
You go into the middle.
Okay.
I'll stand on the end. I know. Onward, onward, everyone. Onward.
Thank you very much.
Thank you.
Thank you, Chelsea.
And now, admittedly, I don't know if I invite the panelists to the stage. Do I invite? I'm going to invite the panelists to the stage. Could I please ask my good friend, Kennedy Odede, to... Oh, Kennedy, you got such an enthusiastic response already. The co-founder and CEO of Shining Hope for Communities, Shafko, whom hopefully you heard at the open of CGI yesterday, Prithvi Kristel, the co-founder, and well, now I feel like you have to cheer for all of them because we don't want anyone to feel like they didn't bring their built-in cheering group and somehow then are less enthusiastically welcomed. So yes, Prithvi, the co-founder and co-executive director of IMAC, the Initiative for Medicines and Access and Knowledge. Dr. Maria Elena Botazzi, yes, thank you. Associate Dean and Professor at the Baylor College of Medicine, and Dr. Raj Punjabi. Yes, great. Also a longtime friend and Senior Director for Global Health and Biodefense at the United States National Security Council. And now maybe just a round of applause for all of them. Great. It's so wonderful to be here on stage with so many people that I deeply admire. And Kennedy, I want to start with you for many reasons. You should have known I was going to start with you, Kennedy. This should not be a surprise. Partly because many months ago, Kennedy sent me a note saying, something along the lines of like, "Dear Chelsea, localization has to be front and center at CGI." And I said, how much do I already agree that we're already planning on it? And now you have to be a featured speaker. And thankfully, Kennedy said, of course, what can I do? And we said, I'm sure lots, but more importantly, what can we help you do? And Kennedy, I know that you have been on the front lines in Kibera of helping navigate the various challenges that COVID-19 both presented and exacerbated. And I know you've spoken a lot about kind of what you learned about leadership and what you observed as to where leadership failed over the last 2.5 years. And I wonder if you could start by reflecting on the last 2.5 years and what you've learned about kind of the importance of local leadership, especially in moments of crisis, and kind of what you want everyone to know about what localization means to you.
Thank you, Chelsea. Yes, so COVID was really, it was a game changer in many ways. So first of all, on the national politics, you can no longer just talk. You have to do something. Because as I said, Chelsea, during crisis, that's when you know the real leaders. And those leaders, most of the time, they come from the communities. The top leaders will be swiped off during crisis. It happened in many, I won't say which country, but through COVID, we see a lot of changes happening around the world. And then COVID for me was something whereby inequality was being seen there. So in Kibera, you hear this thing called COVID. And people thought it was only in the US or Europe, Italy. Those people have what? They have shower, they have fridge, they have food. Don't meet anybody, just stay away. What do you think of someone living in informal settlement where you share the pit latrine, you share the tap water? So it was really whereby we needed people to see the power of community. So we have to really go down on the community and tell them, how can we solve it? This is now upon us ourselves. And the good thing that happened in Kenya is that President of Kenya really appointed me to be in the board task force. So I helped to bring in community way of thinking on how to implement the policies. Thank you.
Raj, you have spent so much of your career trying to build local health workforce capacity and capabilities. here in the United States, in Liberia and Sierra Leone, in many other places. And I was thinking about the first commitment that we began with Her Excellency Ambassador Samate Sisuma from the African Union and PATH. And we have talked about the importance of the work of Last Mile Health, which you helped found and run for many years, of Partners in Health, the work that CHAI tries to do, always in partnership, to build local capacity, to, as my father says, work ourselves quickly out of a job. And yet we still don't seem to have a real kind of existential appreciation for why investing in building local capacities, investing in local leaders like Kennedy, in kind of, in the best sense, sloughing away kind of power and resources, still is not the prevailing mode of thinking or doing. Why do you think that is, and how do you think we change that?
Well, thanks, Chelsea. I think part of it is because we have not told the story enough of the people who've actually helped us from averting those existential threats. I remember being here with you 6 years ago when I had a little more hair, or as my kindergartner likes to say, my head is just shining through a little more, shining quite a bit, I'm sure.
Raj, you're a light in so many ways.
But 6 years ago, we came together here at CGI and spoke and reflected about the West Africa Ebola outbreak, which is still the worst in history. And what you and others, including your father, did when you came to Liberia during that crisis was to recognize those frontline and community health workers that actually helped go door to door to find the sick, first of all, to get people into care, but ultimately to help stop transmission and stop the virus in its tracks, which keeps the rest of West Africa safe. It kept all of us here safe. And the story repeated itself during COVID-19. I was just talking to a colleague in the audience who's been involved in the effort in India to roll out one of the largest vaccination efforts in the world for COVID. And they leveraged and engaged, hired, trained, and equipped local female community health workers called ASHAs there, who helped scale up vaccines in that country. I mean, that story needs to be told again and again, because that is the true story of how we stop these outbreaks. So I think one is the moral narrative needs to shift. But as I've been now in government, the argument I've been also trying to make complementing that is that it's just a smarter way to spend taxpayer dollars. When I was the president's malaria coordinator before coming to the National Security Council, I was told that those dollars couldn't be used to pay community health workers. It could only be used to buy malaria products. It just said, well, show us the policy that says that. It turned out the policy said the inverse, which is you could use funds at PMI through USAID.
Always read the fine print.
Always read the fine print.
Even in government.
Exactly. And so we then shifted it within a month's time and allowed PMI funds for the first time to be used to pay community health workers. Why? Because in some countries, half of the malaria testing and treatment is done by community health workers. And now as we look at pandemic preparedness, Chelsea, and think about the role of surveillance, surveillance isn't just things. It's not just a genomic sequencer, though we need that. It's not just a central reference lab, though we need that. It's also the door-to-door community health worker who finds a patient who may be ill and may not have malaria or a common illness and refers the patient in quickly. It's the nurse at the clinic who has been taught to look for other conditions that might also be worthwhile mobilizing an epidemic response to. It's holistic surveillance. It's from the lab to the last mile. And I think standing for those policies, not just because they're the right thing to do, but because it's a smarter way to use the health security dollar, is something I think we should all get behind.
And, Priti, now, looking to you and someone I've learned just so much from over the last particularly few years, you have spent much of your professional career trying to help expand access to medicines, to commodities, most recently to vaccines. You actually helped lead an effort in the kind of mid-2000s that led to the Indian government actually adopting more kind of patient and public health friendly kind of patent regulations. I wonder if you can talk about your work for people who may not be familiar with it, and how your work also connects to this broader localization, not only conversation, but hopefully shared imperative.
Yeah, so I started my career in the early 2000s working for an Indian organization called the Lawyers Collective. It's a collective of human rights lawyers based all across India. And when I got there, I really had my eyes opened because how the Lawyers Collective approaches law and policy development is centering communities and community input, going state to state, district to district, village to village, and getting community input into even the most technical of laws around HIV discrimination or patents, you know, a topic that's for most people seems really technical, and so how could communities input? And they really, I think, trailblazed in that way. My whole career, I think, at that point, it was the turning point. I could never go back to thinking about law and policy as a top-down systemic tool that didn't necessitate getting community input at every step. And so today, we are global, but we are also based here in the United States. And as during the pandemic, we launched a program called Participatory Change Making. The idea is that people who disagree with each other across ideology, sector, geography, can sit together and look at the drug development system and the patent system in particular to think about, from their different vantage points, what are some of our most pressing national and global problems that are rooted in this system, and how can we start to solve for them? And standing on the shoulders of the Lawyers Collective and many of our other partners, really centering communities in that effort. And it's been a gift, and I hope that it can also serve as a model for many of the other parts of the health system where I think this work still needs to happen.
And Preeti, have you had people reach out to you who recognize that your work, your way of kind of continual community engagement, can and should be a model?
We hear that feedback a lot now. People are saying to us, I think people are seeing the potential for democracy, particularly here in the States, because it's getting so polarized. I think people are starting to understand that this might be a new way to engage across issues. So how do we start to think about scaling that?
Dr. Batazzi, I don't know if everyone here knows that you have led a vaccine initiative at Texas Children's Hospital that helped to develop a COVID-19 vaccine. And I think that is important for people to know if they don't already. And not only in that process, but as I understand it, kind of in your approach to research and development more broadly, you talk about the need for a real kind of ecosystem approach and ensuring that while scientists have to drive the science, determining what the science should focus on and who participates in that science needs to be community inclusive, needs to be, to use a word that Preeti used, as democratic as possible. Can you talk about how you came to understand why that approach was so important and so critical for your work? Is that something you always intuitively have understood, or did you have an experience as a young research student that really illuminated that for you? And then how has that approach influenced your work, including on the COVID-19 vaccine?
Well, thank you very much. It's just beyond a pleasure to be with all of you here. So I think I have to put it a little bit in context with the fact that alongside my science partner, Peter Hotez, which I think everybody knows very well, we've been very intentional because we've been working for more than 20 plus years on developing vaccines for diseases of poverty. And so how do you even start developing a vaccine program for diseases of poverty? And therefore requires that, that the development is done on location, in the sites where eventually these vaccines are going to be needed. And therefore, to paraphrase what all of you have said, we had to go local. We couldn't just design something from the US and then say, here it is, figure out what you can use it for or how you would use it for. So it was very intentional from the start, and we rapidly recognized that we needed to do this kind of reverse innovation where with some cultural intelligence, which I hope you all will appreciate, that we need to look for ways to develop interventions that would fit for their purpose, and enable and empower that those technologies that we may academically be creative for, that we can create them together with the locations that they would be needed. And so we are the case study, right, with certainly our COVID-19 vaccine, but this even comes from years of working on diseases such as hookworm and Chagas and schistosomiasis, right? All money-losing guaranteed, vaccines for sure, but that we needed to incentivize locally. Why would the communities would partner with us? And so therefore, what do you think they liked about it? One, that we would do open science, and therefore we would share not only data, information, reagents, as much as we can. We would teach them how to then walk through that biopharmaceutical process. So we are academics, we teach. But more importantly, remove those barriers that would disincentivize them, like patent protections. Of course, we could do it because we were also using very generic technologies, things that are very well known already in the ecosystem of development. And I think that was the winning strategy. But most importantly is that our vaccine center was created with the premise that it had to be done in partnership and in community. So from the people we would want to target as eventual end users, to walking backwards and figuring out who would be the ones that had to contribute alongside with us to be able to enable this vaccine. And now, of course, with COVID-19, I think finally 20 plus years later, I think people are starting to realize that we can break that paradigm of how we can create, develop, test, and eventually incentivize the use of vaccines from the ground up, from where you need them.
And Dr. Bertozzi, I just want to follow up on that last point of, after 20 years, and in the context of a global pandemic, maybe now you have pushed back against some of the cynicism, some of the racism, some of the colonial mindset, some of the misogyny. I mean, you have faced so many kind of structural and cultural and kind of, draconian normative barriers, and you leading this work in the way that you have. What does finally give you hope that maybe there is an appreciation for the way that you have worked, and even more so, similar to kind of what Preeti was saying, an understanding that this needs to be a model, that it's not only more moral, but it's actually more effective and efficient over time?
Yeah, there is still some skepticism. Arguably, I have to say, we have to recognize that. But I think it changed and it empowered, in our case, for example, it empowered the local producers to shift from always being considered what we call follow-on, meaning that they just received something very mature, and therefore they would just follow on somebody else's, big contribution investment, to becoming real first-rate innovators, and therefore developing it indigenously, and that's a sense of proudness. And I think that sense of proudness, and then seeing that their people, the population in India, we have more than 75 million kids vaccinated with Corbevax, which is biological ease vaccine that we co-developed. They feel so proud that they could accomplish this, that now they're enticed to do more, right? And more, and then Biopharma from Indonesia jumped in later on and said, we also want an indigenous-owned vaccine. And we're going to make it halal certified. And so we knew that already way when we were kind of like crafting our strategy, that we needed to be culturally intelligent. Again, what technology can we use that we could fit many purposes? And then, of course, now we have Botswana, who's building infrastructure to eventually learn how to make the vaccine. So I think it's a snowball effect. And it's just that we need all of you to just raise the voices and empower them and saying, you see, we can do it, you can do it. It doesn't have to come from the US to tell you how to do it. You can create it by yourselves.
Kennedy, you've spoken now for so many years and crucially throughout COVID-19 of the importance of bottoms-up leadership. And you shared earlier how you were part of kind of the President's Council, in Kenya on COVID-19, and certainly, during COVID-19, similar. I was reflecting, Raj, to what you were sharing about our time together in West Africa, similar to what we saw in Ebola, where in a crisis, national leaders, people sitting atop multilateral organizations seem to have the capacity to understand that local agency really is critical to helping ameliorate harm during a crisis, even one of historically unimaginable kind of proportions like COVID-19. But when it comes to then rebuilding or building resilience or taking kind of the lessons we hope we've learned into practice, the appreciation for investing in local leaders in the bottoms-up approach that you not only advocate but exemplify seems to not be as robust, doesn't seem to be as clear or intentional. Why do you think there's that disconnect, and what do you think can shift so that national and international, global leadership can continue to understand why in any moment it's important to not only listen to, learn from, but invest in local leaders?
Thank you. Chelsea, I'm just worried that the world is going round and around. People will come to conferences, we'll talk, we're going to raise billions of dollars. I think we should start asking tough questions like, what is the accountability? Yeah, we are going to have a commitment. How are we going to measuring this? Because I'm happy that there's a talk about localization, and everybody will tell you that, yes, now we are going local. But really, I went to my village, for example, and there's malaria money. Fishermen are using malaria nets for fishing. Yes. And, why? People are not involved in the community. It goes from top to down, right? And these are people that I meet today in my life. For example, in Kibera, during COVID, I meet this woman, really sad. And I'm like, hey, where's your mask? He said, Kennedy, 100 shillings is $1. Should I buy a mask or buy food? I'd rather die from COVID than to die from hunger. You know what I mean? There are people who live on the ground. So I think it's the right time we have to make people to be accountable and ask them to accountability, right? And because there's something here. This is my friend. Now I call him government. Yeah? I have to push him a little bit. We grew up together as young entrepreneurs. Let's be honest. My brother, you did a good job with the community in Liberia during Ebola, and Chelsea knows this very well. You had all these things really written down, you have seen the experience. But there was COVID. Why the Americans and the world could not borrow what worked in Liberia? Why? And that's the question that really disturbs me, is that we look at the local people with no dignity. We don't value them. We just talk about them. And even the word frontline workers, forgive me, it is changing. Frontline worker, yeah? So it's true. We have to start changing that and respect those who are working on the ground. That's the only way we're going to have a major impact. And when we meet places like this, don't be quiet. Ask for measurement and accountability. Thank you.
I agree. So Raj, I think you have to go next. Both because, as Kennedy said, you used to run an organization, you're rooted in your local experience, right? In your country, in communities where kind of you had grown up as a child, and now you've had a series of very kind of big jobs at the U.S. government. And so how has your experience at Last Mile Health influenced kind of what you've done, and what more do you think needs to happen, since the U.S. government is the largest funder by far, kind of into kind of health and public health around the world, to better answer Kennedy's questions?
Yeah, I think your points about measurement and accountability is absolutely essential. And when we are more local, there is more accountability, because people know exactly which community that you're supposed to deliver the bed net or the vaccine to, and and someone can push back on it. I think that the first thing I've learned is that you just have to have a certain amount of humility. You cannot ever, to your point earlier, assume you've done enough, certainly not with the resources that we have. We are proud, the United States is, of the 600 million vaccines that have been provided around the world, COVID vaccines, to over 116 countries. But that's not enough. And that's why we have asked Congress now for several months for additional funding to make sure those shots get into arms, to make sure that, what do we mean by that? It's vehicles and fridges, it's local community health workers and nurses being trained and hired to do the work. And I think that
And then you have to keep hiring them to do the work.
And then you have to keep hiring them to do the work, as was, to ensure that you're not just protecting us against the next pandemic threat, but taking care of the everyday epidemics of premature death, whether it's from maternal complications of pregnancy or childbirth, or it's hunger or malnutrition. So the challenge is trying to hold accountable, as I've seen in government, all branches of government. It's $4 billion that's been asked that's still sitting on the Hill to get shots in arms, to ensure we get those vaccines delivered to every person that needs it. And as you noted earlier, while a lot of the world has now had access to vaccine supply is no longer the challenge, the delivery has not occurred to all the places that need it, especially some of the most, and it's not because they can't do it. I mean, to your point, these are some of the most gifted leaders and doers, and we've seen it just in the last few months in places like Uganda and Ghana and Tanzania. Vaccination rates have climbed for COVID within weeks by 10, 20, 30, 40 percentage points. So they can do it, but the resources have to be there at that local level as well. And
Chelsea,
I agree with you about
please forgive me.
No,
Shut
kidding.
down
Go
my
for
mouth.
it.
Oh, I'll speak once, I swear.
No, don't speak just once. Don't limit yourself.
Chelsea wrote something here about community health workers, community health volunteers. Let's be honest. Why do you have to talk about frontline workers? You know why? They are not respected because of something called the Western world. The policymakers don't want to appreciate their lived experience. You can come from big university, we'll pay you, but because you are a community health worker, a woman in that village, what makes you special? Lived experience. Let's start appreciating lived experience as also important. Thank you.
Well, I would say as expertise, right? I mean, that's actually an expertise in and of itself. In fact, the most valuable of expertise. Policy, I'll just say one last thing and then we want to turn it over. But we, in a crisis, we often worry about trust or the lack thereof with the communities you're trying to raise to. It's because we haven't invested every single day in the dignity of those people to ensure they're at the table. It's why with this new pandemic fund that's been launched at the World Bank to help prepare for, and respond to future pandemics, the President and the G20 were key allies in moving that forward. The United States argued for civil society organizations to not have just a seat, but to have 2 seats at the table that are just as equal to the other governments there. And I think that was a harder fight than it should have been.
I think one of the challenges we have, Kennedy, is it's very hard, I think, here in the United States where we don't do a very good job of protecting or respecting or recognizing the dignity of our own frontline workers. And so I think that also just has to be honestly acknowledged in this conversation. Priti, Raj spoke understandably a lot about the vaccine donations from the United States. And as you and I both have written and spoke about, we are clearly grateful to the donations of the United States and other countries of the vital life-saving COVID-19 vaccines, and also think that there should be a different structure at a global level for vaccine development and distribution. And clearly, what is being done and has been modeled so well at Texas Children's kind of should be persuasive enough and yet hasn't yet been. Can you talk about what a more kind of equitable system from a legal and regulatory perspective would look like, and why that is so vitally important to this conversation?
Yeah, so I think what we saw over the last 3 years, what we learned is that our system for drug development and distribution isn't as objective as we think. And through COVID, what we've really seen is the stark inequities in what is developed and how it gets distributed. The major challenge that I think we identified when we wrote together is how are we going to solve for this time gap that we still, 20 years after the HIV epidemic, we're still not solving for. Drugs get brought to market, and then it takes years to get those drugs out to the people who need them most. And a lot of that is because we're still, even through COVID, relying so heavily on donation and charity-based models. There are experts, advocates, community leaders who have been pushing for local and regional production all over the world. People in Brazil and Thailand, Ukraine, Argentina have really shown us the way. There are models in country. I think this is really going back to Kennedy's point. It's who are we choosing to listen to? Because the models exist. Local production has been shown to be successful. Where there are barriers like intellectual property, I just think it's so important to remember these are not scientific barriers. These are man-made barriers, and we have a choice. We have a choice to do this differently going forward, and I think that it starts really with who are we listening to and how can we learn from the models for local and regional production that already exist all over the world today.
I think it is important, what Preeti said, in that there are dozens and probably well north of 100 places that could manufacture the COVID-19 vaccines today if there were not the current IP barriers that persist. That should be upsetting to all of us, and hopefully then galvanizing to each of us. And Dr. Bottozzi, I want to ask you again, what do you think, kind of based on your experience, a real equitable kind of R&D model would look like around the world? And how do we get there to ensure that it is ultimately, community-led, driven, and owned?
The gazillion-dollar question, right? Honestly, diversification, right? I guess with coronaviruses, I think we were a bit lucky that, pretty much any technology you threw at it, it was successful. RNA, protein, viral vector.
Can you talk about, because we were lucky.
We were lucky.
Can you just talk a little bit about that before?
Well, one, we were lucky because we had years of studying the coronaviruses, right? I think people, when they claim that, it was quick and fast, for example, even our own laboratories, we had more than 10 years studying SARS and studying MERS and other viruses. So it wasn't, so when of course, it came from the similar family, we had already a lot of the knowledge. So I think, therefore, investing in academia, certainly, or research infrastructure that learns all these viruses and diseases, how they react, how they behave, host pathogen relationships, immunology, all the scientific disciplines is important. But I think to make it then reach the last mile, you really need to not think that you really need to forge these partnerships, very early on. So we, even not knowing if we ever going to reach that last mile, we need to already know who eventually could be enticed to be a manufacturer, where the vaccines would eventually go to. So I think the diversification of not only the knowledge, but the partnerships. I actually have to say, also, since I know you were up here on the stage, groups like PATH, we were not successful just because we were alone. We were successful because we had organizations as PATH behind us, or funders like the Skoll Foundation, or funders, even local funders. So it's diversification not only in scientific, approaches, partnership approaches, again, cultural intelligence of how those can be diversified depending on where you are. But ultimately, to be honest, the real secret is who will be implementing and who's the workforce. And so again, as educators, as we are living in an academic, environment, people are the ones who eventually make things happen. We create the barriers, but we are the ones who can remove those barriers. And I think there's ways of doing it in a way that we can do it in a balanced and diversified way. That doesn't mean that you can take only one pathway. You can take multiple pathways. And some of them are appropriate in certain situations. During the time of the pandemic, at the beginning was very different than what we have now. So, and it has to be flexible enough. And I think we scientists are very flexible, adaptable. We can change immediately. The policies, the regulations, the funding streams, those were not flexible enough and fast enough to accommodate, to be able to address all the needs in different areas around the world.
I want to open the floor up to the questions from the audience, and I apologize that I can't see, because despite what I tell my children, I'm not a superhero. I can't see through the lectern. So if you are sitting, and if you can't see me, I guess it's like safe to assume that I can't see you. So I'm so sorry that if you are kind of in this area, could you please come into the aisle if you have a question, because otherwise we may not see your hand go up. Though while hopefully you are thinking of questions for our wonderful panelists, Kennedy, I do want to ask you, so often, and I feel only slightly guilty because Raj, this was prompted by something you said, but not guilty enough to not ask it. So often, there is this framing in kind of multilateral institutions of, well, we've given civil society a seat at the table or 2 seats at the table, instead of we should let civil society set the table. And then we should have a seat at the table.
Yes, I agree with you. And that's why, Chelsea, we have to be really careful of tokenism, right? And what people want is just, as I said before, is all about dignity. Are you really listening? What is it? You cannot just say, we invite you, right? So that's not allowed, So I think we really have to have a real change happening. And they don't have to be on your table, but are we listening the ground? You know what I mean? Because for me, in my life, the best things I've seen is where community are really in charge. And the simple things that are really having a bigger impact than those complicated things, yeah? And also upon us, those who are coming to places like this, how do we take these messages back on the ground? We talk about SDGs. Do you walk on a street in Liberia? Do they know what SDG is? You know what I mean? That's the question, no? So we really need to work hard on that and listening to the local leaders and communities. Yeah.
And I certainly agree on the accountability point. We believe in measuring everything. I once had someone, not once, like a few months ago, say to me, oh, but the things that matter most you can't measure. It's really about how we feel. And I thought, well, if you don't have clean water, or if you're not able to earn an income, or you can't go to school, I bet you feel really awful about that, and about the fact that your child is going to die of a preventable illness. But it's what we can measure and shift that hopefully is going to make you feel better, right? And they're like, well, I still think it's about what we feel in our heart. And I was like, we are just going to have to agree to disagree here, because I think unless we have accounting, we cannot have accountability. And so often we somehow expect accountability without the accounting. I saw a hand up over there. Yes, sir.
Hi there, I'm Mega from the Desai Foundation, and I really appreciate this conversation about bringing local leaders to the table. We deployed a program called Heroes for Humanity during the pandemic, where we hired people from the villages to serve the villages. And one of the things that I would love to ask with this esteemed panel is, we had a lot of trouble raising money for this project because people seem to not think that just because these local villagers weren't doctors, they couldn't administer a diabetes test or administer a COVID test. And I just would love to know if you have any insights and advice on how nonprofits can convince donors that not everyone has to be a full-on medical professional to be able to screen and triage medical help in local villages.
Have they ever gotten a prescription from their local pharmacist? Where do they go for their flu shot? who gives their children their vaccinations? It's probably not the pediatrician. Sorry, I'll let the panelists answer.
I think there's a huge guild mentality that has to be broken, and I think asking the questions Chelsea asked is critical, but seeing is believing. And to be honest, when I first saw the Alaska Yupik community I think I was 20 years old, and they gave me the chance to volunteer with them on the tundra, and to watch them 50 years into a journey where they had already in the 1950s vaccinated children for tuberculosis at the time, then vaccinated children for other things, to then be dealing with kids with ear infections, multiple ear infections, able to take video pictures of their eardrum to send, but also to place EKG leads for adults coming in for chest pain who may have heart attacks. It was powerful. I think the other thing is we have to push back, right? First they laugh at you, then they fight you, then they ignore you, then you win. And I think that the Alaskans actually got taken to task because they introduced microdentistry to those same community health workers in the tundra, because no dentist had come. 40 vacancies for 40 years. For dentists, no one had come out there, and kids had massive, well, guess who's tried to sue them? The American Dental Association did. But they lost. The American Dental Association lost. Why? Because they showed that these workers were actually safe, effective, and then they pointed out, in fact, we had 40 vacancies for 40 years, and none of you ever came to fill. So I do think there's citing some of those examples where that is also another part of it.
Ritzy or Kennedy or Dr. Potosi?
Maybe just a note that, again, what is really important is to show the capabilities, and sometimes to show the capabilities, it's experience on ground, right? And I think and when you ask, how can you convince funders? I mean, if we all had a magic one understanding, each of them. And I think it's really, again, by just seeing, right? Sometimes it's hard when they actually don't see. So maybe bring them over and show them what it's all about, because from afar, they may not see the right, they have maybe a different perception.
Yeah, and just for me, it's a common sense. Right? I call it, let's make it simple here. It is called a trust. In my community health workers are the doctors and therapy. At the same time, it's just, they will gossip, talk about things, and something's happening. So we need to encourage them, telling them that, okay, it's about trust. They can't go to a doctor. We don't trust them, When you say community health worker, you know the history of them. You grew up together with them, or you have seen them, mother of so and so. And there's something called trust. That is why we are implementing this. Thank you.
Serena Rosso is my name. I'm from Australia. Firstly, I want to congratulate CGI that we're back. I've been coming to CGI for the last 10 years, and it's so invigorating and so timely after this pandemic. But my question is, as an educator, and I've been in this business for 43 years, mental health. I do welfare to work all over Australia, and also in the UK and hopefully here. I just want to have your interpretation. The youth have been suffering mental health because of the, home isolation. Adults have been suffering. We've had massive resignations, silent resignations. We're in the most disruptive workforce in the world. How can we work together on mental health? And that's not just, the younger generation, the workforce, but also leaders, leaders in companies that are committing suicide. I just want your viewpoint, and I'd like to disrupt by being able to say, I want to come home with some solutions. Chelsea, you've really grown up. Congratulations.
Well, thank you. We are facing an adolescent and a youth mental health crisis around the world. Here in the United States, we have unprecedented levels of depression, anxiety, and suicidation among 11 to 15-year-olds, and unprecedented levels of quite young people taking their own lives. And so while I am closer to the statistics here in the US, I know that WHO and others have really raised the alarm for the crisis that this is around the world. I wonder, if we can start with you, Kennedy, if you can share any thoughts or reflections of kind of building on what you were just saying around community health workers often being kind of also, including kind of mental health work in their work, and kind of what you may have seen to work in Kibera that the questioner could learn from, whether in Australia or anywhere.
Okay, I think mental health has been something that has been happening a lot. For example, in Africa, most example in Kenya, for example, is that it used to have a negative connotation, and we are changing that because it's not honest. If you think about it, in my community, there's no therapist, right? In America, some people can afford, but some people go to churches. There is elders of the church. There's women groups, and people end up really supporting each other. And what I've seen in Kibera, it happened to one of my best friend, and I really up to now I regret. He was looking for me. I was hustling in a job in a factory, and I've been busy. This guy is looking for me all the time. I said, I'll see him. What happened? The guy committed suicide. Yes, and I carry it up to now, so I really talk more about mental health. So why? In my community, check on each other. Talk to everyone. Know what's happening to your neighbor. Even in America here, people I know we needed to make it to expert. I agree. But we can also solve some problems. People want just to talk to you, share what they're going through. So in my community, that's happening through these churches, there is communities. And then apart from that, we're also training the community health workers, leaders, imams, on mental health. So it's become part of their life. Yeah, so how do we make it local? That's the point, And because when you are going through something, you feel you are alone. You feel you are being judged. So sometimes you just want to know that someone is there for you. And most of the people I saw in UK, somebody has been in the house dying for over, I don't know how many months. Nobody knew that. You saw that, yeah? Why are you living that way? We are human beings. We have to take care of ourselves, and checking on our neighbors. So that's what we do in my community, making sure that everybody is no longer, it's not a problem. It's part of life. In Kibera, mental health is part of life. Sometimes things get tough in life, but how are you there for each other? That's how we do it in my community. Thank you.
That we all have to take care of each other.
Yes.
One of my friends who's a middle school principal told me that while they've spent a good number of years trying to teach children, middle school age children, to use their phones less and to not use their phones at all during school, they've recently tried to help kids understand the importance of calling their friends to check on them instead of just texting. And when she asked at the beginning of the school year, like, how many of you have used the phone to call a friend, like over the summer, almost no hands went up.
Can they work on calling parents too?
I'll tell her, Raj. I'll tell her. But please, Dr. Watosi.
Can I also give a slightly different perspective? Because certainly, what triggers, mental health issues may be many things. And living and working and witnessing, again, neglected tropical diseases, many of them are silent diseases, stigmatic diseases, which, putting aside a little bit COVID for a second, we have burdens of these diseases all over the world that are actually influencing, this mental health crisis that we have. And therefore, I want to bring it back of why it is so important to develop vaccines, in this case, against many of these neglected diseases that are maybe not big killers, but they're clearly huge morbidity diseases that are also impacting the mental health of our kids, because they grow with these parasites and these diseases that basically they live in disability all their lives, which ultimately affect not only their health, but certainly their mental health. And maybe that's a spin for the incentives of why do we need to develop more vaccines against these infectious diseases, not only when the ones that are going to appear out of of an emergency or a pandemic, but the ones that are there now, right? Not the ones that we don't even know what will appear later, but focus on those that are already causing a lot of this mental health burden.
Well, Anne, I know you said we weren't going to talk about COVID, but we know that long COVID has had enormous impact on mental health, and we know that millions of children around the world have lost at least one primary caregiver to COVID, and so that trauma and the ricocheted effects, the durational effects of that trauma, also, of course, relates to mental health and well-being. And so I know there's such an impulse among so many people to put COVID in the rearview mirror, despite the fact that at least in this country, 400 to 500 Americans die every day. But we are still living with and will be living with for a very long time.
And we won't know those consequences until years from now. So,
Yeah.
Raj.
No, I was just going to say, it's coming back to the point about mental health and community-based solutions. I think when we use the word community-based, it sometimes sounds like it's too soft. It sounds like it's not concrete enough. It sounds like it's not effective enough. The truth is, even a community-based methodology has been applied to mental health. If you look at the group Sangath, led by my friend Vikram Patel, who's trained in mental health, has managed to, of course, it's always in teams, but there are community health workers in India who have been trained to help screen initially with 2 questions: who might be depressed, and a nurse, not a psychiatrist, but a nurse who's trained to then provide and start administering therapy and/or treatment. And I think it comes back to a lesson from our dear friend Paul Farmer, the late Paul Farmer, who often said that community-based medicine is not substandard care. It's actually the most modern version of it. And I wish we had more of that here in the United States. If we had that, we might be able to get even more vaccines to people during this pandemic. We might be able to deal with the next one better, and the everyday epidemics of suffering that we see.
I know we're out of time, and I'm so apologetic to the people who stood and did not have the chance to ask our esteemed panelists your questions. I hope that you may have the opportunity to find them individually later. Kennedy spoke about the need to give dignity. We also need to give resources. And so while it is hugely important that we listen, listening without action is still charity and not solidarity. And so I hope this has been activating as well as informative. And I hope that you will now join me in just enormous gratitude for Dr. Batazzi, for Preeti, for Kennedy, and for Raj. Thank you all so much.